Good evening, everyone. Welcome to this evening, and thanks to Rayner for putting on such a great opportunity to talk about something which I think is very interesting. And before carrying on, I'm going to ask the speakers to come up. Damien Gatinel, Filomena, I'll give you your formal introduction before your talks. And of course, Georgia and Brian Harrisberg. Come up on stage and take a seat. I think the best part about, and Dean Corbett, come through. So Rayner asked me to give a brief introduction to EMV and just touch on how this all came about. So EMV is, after many years of thinking about lenses and lens designs and optics, a solution that would, in my mind, give patients some solution to their reading ability, but a solution that will give them the best satisfaction with the least compromise in their quality of vision. And that concept was something I called EDF, extended depth of focus. So, you know, we were surrounded by multifocals and being promoted very heavily. And although I had started multifocals when they were first introduced in about 91, 92, and I was one of the first people to use the 3M multifocal, I soon became aware of the limitations and the compromise. And my solution for many years was modest monovision. And, you know, we've all spoken about it at AUSCRS many times. A good solution, and but takes you so far, because it limits you what you can actually provide in the defocus in the myopic eye. It's about -1.25. And you don't have troubles with that, but of course you still need spectacles for, you know, some activities. Not a deal breaker. Many patients were happy. But could we do better? And when looking at all the multifocal concepts, trifocals, diffractive, refractive, none of them appealed to me. And I thought, well, gosh, maybe what we need to do is extend the depth of focus to a certain amount, and realizing that you can do so much and no more before you're going to compromise vision, even with extended depth of focus, but staying within the boundary. Having a lens which would pass all the criteria for a quality monofocal, but a little bit more extended depth of focus, and combine that not as an afterthought, but with intention, with a level of myopia in one eye to get an augmented effect, a synergistic effect. And that was the kernel of the idea. So this was before Symphony, before any of the other lenses we're familiar with. And the story is it's taken 10 years to find a partner to take that concept to the market. And it was worth the wait, because those of you who have worked with Rayner and know Rayner know that this is not only quality vision, but it's a quality partner. And I'm really grateful to Rayner, not just for making this a reality, but in the manner that they've done so, responsibly, but with enthusiasm. Not easy for a company to embrace, you know, introducing modest monovision. Most would shy away from it. So this is the culmination of 10 years, and I'm as excited, if not more so than you are, to hear what this amazing panel that's been put together this evening, their thoughts. This is the most fun part of my career, sitting back and rather than necessarily speaking about something that no one's quite heard of, but something that's being used practically, and hear other people's experience. And so I must confess it's a very enjoyable thing to do. So I'm really looking forward to hearing what they've got to say. And without that, I'm going to introduce our first speaker. So, I mean, really, they've all spoken already at AUSCRS, so we know the new ones who are the first time and the ones that have been several times, and Karl roaming in the audience, and we know all these people. But briefly, Damien is kind of like a brother. We do the same things. We do ROL formulae. We do apps for toric alignment. He's much more learned. I mean, he's a mathematician, but we also share an interest in optics and science. I'm not going to read out the full CV I've got, but just to say he's one of the leaders at the Rothschild Institute. And if you want to understand optics, you should listen to Damien, because he has a deep understanding. Not only that, but he shares it in a very clear and lucid manner. So Damien, you're the first speaker, and your presentation is EDOF Optics, Reality or Myths.
Thank you, Graham, and good evening, everyone. Thank you for inviting me to this very nice setting, and for the kind introduction. It's always an honor to speak under Graham's control, and so I will speak about what we are doing now in our lab. I would just start by this picture for you, which is to me a nice introduction to the optical qualities. This is what probably you would call a halo, and this is a gravitational lensing effect from the complex theory of cosmology, which says that light can get curved when it travels through space, when there is a big mass that can kind of modify the trajectory of light. Why do I show this? Because when I first saw this slide, this scheme on the left of my slide, I was intrigued by this kind of a curved light path, and this is an example of some simplification sometimes you should avoid when you deal with those concepts where usually light travels straight, at least in the same media. And there's a lot of terms that have been put forward over the last years, and they are mostly kind of, I would say, marketing artifacts still to disguise the blunt truth, which is that light is usually absorbed, reflected, refracted, diffracted, or scattered, but there's no much more than that, and you have to deal with this to design lenses. And again, we've studied diffractive lenses, which is not my topic, but from the structure of those lenses, we published that we can derive their optical properties more or less, like, for example, the first EDOF lens, which was seriously, would say, introduced as a non-diffractive lens by its manufacturer over the last years, has been now accepted to be a true diffractive IOL with spacing which shows that it is a bifocal, distance, and intermediate in some ways. So EDOF lenses were introduced a few years ago, and they work with 2 or 3 principles, at least negative spherical aberration for most of them, positive spherical aberration for the Rayner, and for the alconvivity, a wave front stretching concept, which is not very well described, but which tend to suggest that it is a specific mechanism. We have acquired this instrument in my department, which is, again, to make it simple, a photometer to analyze IOLs. And what is nice is it can reconstruct diffractive profiles. So this is, for example, here, the comparison between the trifocal IOL, the fine vision, and below it, VVT lens, which we put. And as you can see, it's probably not a diffractive lens per se, but it may have diffractive element embedded, as shown on this comparison between the lens. This is again a trifocal lens, and this is another trifocal from Rayner down below, and you see that what we reconstructed in the middle of the slide is very close to what the manufacturer claims for its diffractive trifocal profile. So that was the introduction. Now, dealing with refractive IOL, this is what we measured as the spherical aberration of the Rayner lens, and it's obviously a positive one on this diameter for a 20.5 dioptric element. And what we've done then is to calculate for different IOLs, or measure, I would say, the positive spherical aberration. So the RayOne is the dark blue curve here, and you see it's originally inducing positive spherical aberration for all pupil diameters until I think the diameter of 4.5 or 5, where it becomes negative again to balance a bit. It translates in this MTF curve here, which is a kind of bifocal curve. But if you would compare this curve to, in fact, the monofocal spherical IOL MA60 AC curve. It's very close. But this is again for a 4.5 aperture and a spherical aberration of 0.21. The problem with those lenses is that when you see curves, they are always referring to a specific aperture and spherical aberration. And these are different lenses here, the EMV, the LuxSmart, the VVT, and the INs, for a 3 mm aperture and for a specific corneal model with positive spherical aberration. You see they don't behave the same, but they all have an extended kind of MTF curve with one lobe, two lobes sometimes, but that may change over the different pupil diameters. So as you know, all eyes are different in terms of spherical aberration and pupil dynamics. And on average, the pupil dynamics and spherical aberration makes that for spherical aberration, average would be on the 6 mm pupil, 0.28 Zornicki coefficient. If you do MTF, this is for spherical IOL, not the Rayner MA60. You see for a small pupil, regardless of the spherical aberration, the true focus curve is the same. But if you dilate the pupil, asphericity tends, the corneal asphericity I'm saying, is interfering with the lens asphericity, and the peaks are shifting. And they are lowering because of the impact of spherical aberration and also shifting toward the right to more power, and etc. So this led us to design new metrics and a graphic where we put on one axis the spherical aberration, on the other axis the diameter, and we put colors. The higher the peak, the better the optical quality. And this is giving you now a matrix where you can interpret maybe a lens more comprehensively. Although usually the only points you have on ISO 1, ISO 2 corneas and specific diameters are the 4 I show you. But now we have a broader picture. This is again a spherical monofocal IOL, you see. The red color means less quality, the green and blue means more quality. So we, of course, analyzed the EMV lens, and you see that the EMV lens is very close to the spherical IOL. It has probably a bit of a lesser optical quality because you need to extend the depth of focus to some expense, which is, the optical quality is trade against depth of focus. And depth of focus we assessed as the area above the curve here through some modulation of the focus. And this is what we obtained here with the EMV. So you see there are zones for 3 mm pupil diameter and corneal spherical aberration in the average range. It works quite well, and it provides you with a large depth of focus. But of course, if you dilate the pupil or if you move to exotic spherical aberration values, the lens behavior changes. This is compared again to the classic monofocal spherical on the right. You see that there is more depth of focus because the colors are yellow and green instead of yellow and orange. And that shows and demonstrates for us the extended depth of focus over a spherical IOL, which already provides you with some positive spherical aberration. But I think, as Graham explained, they made it more prominent to extend the depth of focus beyond what you would have with a spherical IOL. So in conclusion, I showed you in this slide here, on the top, the chart displaying the relation between pupil diameter and corneal spherical aberration. The color shows you the optical quality for a distance vision, and there is a bit less optical quality than with the spherical IOL, but what the good news is that what you lose a bit, you gain in terms of depth of focus, which is shown down below compared to the reference spherical IOL. So again, this is a nice, I think, objective way to assess that this lens is doing something specific and achieve a superior depth of focus than a monofocal. On this, I thank you for your attention.
And my pleasure to introduce our next speaker. Filomena, you've already spoken. Her CV is amazing. Biomedical engineering, head of department, University of Lisbon. It really is worth, I'm not going to go through it now, but it's spectacular. But equally spectacular are her presentations, how she explains things. And Filomena today is going to give us her presentation on a comparison, and that's really what we want, between enhanced monofocals, and EDOF IOLs. Filomena.
Thank you. And first of all, I would like to make my disclosures. And my disclosure is that I really love presbyopia correction IOLs. And you can understand why. And the truth is, well, we have bifocals, trifocals, we try everything. And for me, the true revolution in presbyopia correction is the enhanced monofocals. And right now, we have this opportunity to address what I like to mention like the functional vision. And if we listen to our patients, if they are correct with monovision or presbyopia correction IOLs, we understand that they still complain about the intermediate vision. And it's true that lifestyle is changing a lot, and right now we have a huge aging of the population. We have an increased active years of aging, working, and we need to address this. So we have this opportunity, the enhanced monofocals. What we need to understand is, are they effective in terms of distance also, intermediate, how they behave in near vision? What is the rate of spectacle independence in these patients? And main is there are some trade-off with this kind of IOLs. They have adverse effects or dysphotopsia. So that's why I would like to show you our experience with different kind of IOLs, range between the enhanced monofocals and also EDOF IOLs compared with a monofocal IOL. And I would like to show you the focus curve. As you can see here, we are comparing with a standard monofocal IOL, which is the Technis. Then we have the IONS, provides a little bit more of the focus curve. And then we have the so-called EDOF IOLs. And in yellow, we have the RayOne EMV. And you can see how this IOL can provide more of intermediate vision, almost comparing with the EDOF criteria. So right now we have this opportunity, and also, I also like very much the IOL power calculation. You can see how we have here a broader peak that gives us more tolerance to refractive residual error. What about visual outcomes? When we compare the distant visions, we don't see any kind of difference between the monofocal standard, so-called, and these enhanced monofocals. But when we go to intermediate vision, we really see the difference between these two types of IOLs. Of course, for near vision, they are not totally independent, but for the kind of lifestyles of today's people, we can understand that this type of IOLs can provide a very good functional vision for these patients. We need to address the problem of the contrast sensitivity, and you can see here that, and again, the RayOne is the yellow. Compare with the standard monofocal, we don't have much of a loss. And the same happens in mesopic conditions with glare. So we are in safe conditions. For photopic phenomena, also we don't have a difference between the so-called standard monofocal and these enhanced monofocals. So the reality is that they still need glasses for some kind of near vision, but for intermediate vision, they perform very well without compromise the distant vision. So we have good results in intermediate vision. We have a good contrast sensitivity. We don't have more dysphotopsia. And this is what I mean. This kind of IOLs could be the new standard of care for our patients. And this is a true revolution, because we need to address presbyopia in our cataract surgery, and really is an opportunity to give and improve the day life of our patients and preserve the functional ability of our patients should be the goal of our cataract surgery. Thank you so much.
My pleasure to introduce Georgia, practices in Victoria, and an ex-fellow of mine, Paul Ursel, said, you must keep an eye open because she did her fellowship training in the UK, and he said, just keep your eye open for her, and she's really special, and he was right. So I'm pleased to introduce Georgia, who's on the cutting edge of new technology, new lenses, and she will give her experience on EMV case studies and toric stability.
Thank you. Before I start with these cases, just while we've been discussing, I've been thinking about those really difficult patients like you, who come to you and they're just a little bit myopic, and you're saying, well, I can do distance, or I could do near, or I could do this, or I could that, to reduce glasses for A, B, or C, and they say, but I don't wear glasses at all for anything. So I think in some ways they are actually the most difficult patients, trying to simulate what their little bit of myopia and their cataract and their aberrations are giving them. But anyway, so I'm going to present a few of my cases. I have financial disclosures. With any new lens, it's probably not a bad idea just to start off with some easier cases, and we're all taught that for trifocal lenses or perhaps EDOFs that we should start with a hypermetrope with bad cataracts, so they basically can't see anything and anything would be an improvement. And this doesn't really apply to this case, but it's, I suppose, not a bad idea when you're beginning with the new technology. So this is a bloke who was referred to me with cataracts, and he's a little bit shallow with his anterior chambers. So his uncorrected vision is not great, 636 and 660, but he refracts up pretty well. I do a lot of milder cataracts in the inner suburbs of Melbourne. So vision 6.6, 6.7.5, but he does have a bit of primary angle closure, is on the border there. So there's a couple of reasons to treat his cataracts. Now, this is a bloke who, for some reason, this has not carried over well, but he has a low degree of astigmatism. His keratometry is a little bit flat on the orb scan, but nothing too exciting about the topography. So low degree of SIL. And this chap was pretty keen on reducing his spectacle dependence, but I do tend to look at angle kappa. Now, I know that we're talking more and more about angle alpha, and I don't have access to devices in all the places that I work to measure angle alpha, but I do look at kappa, and I find it useful, and I think it's useful to look at these images from the IOL Master 700 printout. So he's 0.8 on the right, 0.7 on the left, and you can show patients these pictures on the bottom of the screen there, where the reflections, the Myers there, are displaced from the pupil centre, and show them a picture of show them a model of the lens and say, look, if we put this in your eye, there is a chance that the light's going to go through the rings, not through the middle, and then you might get those glare and halos, and here's a picture of that. So I wasn't terribly keen on a trifocal for this chap, but I was keen to offer him something more than just distance vision. I used to use a lot of monovision, just standard monofocal monovision, and I would do the dominant eye for distance, and over time I would add more and more myopia. I guess I started around about -1, it's not quite enough. So I was probably aiming for somewhere around -1.25 to -1.5. And for some people, it's just brilliant. They come back and they're sitting in the waiting room with no glasses, and you're like, great, this one's gone really well. But on reflection, the ones who don't go so well, they're kind of your unhappiest patients, because if you don't get that distance eye really good, they're not happy. If the near eye is too much or too little, they're not happy. And the near eye might interfere with the distance eye. So there's just lots of reasons why I've found that I'm moving away from that. And that's probably at a time where the EMV has come in for me and kind of blended the gap between the eyes. So, but anyway, for this case, I decided that we'd go ahead with the RayOne EMV, really with a plan for plano in both eyes, because this was one of my earlier cases. And this bloke's done really well, I think. He's 6'6" in either eye. Now, we heard from Dr. Hill today that it's not good enough to just be 6'6" and assume the refraction's plano. So he actually is refracting up to 6'5". He's got a small myopic residual refractive error, but doing pretty well with the near vision. So with this guy, I've just got binocular measurements that we did in the practice, J5, J8, and I've got records from my colleagues who'd seen him in the practice who said he did a crossword without glasses, and he's putting glasses on to read the paper sometimes, but mostly free of glasses. So I think that is success, but most importantly, he is happy with that. This one I think is quite interesting. So a patient who's interesting for medical reasons, and I've done a bit of a mix and a match approach with this lady. So she's 52, she's a clinical psychologist, but she's on her computer a lot. So screens are really important to this lady. She's 52 and she's got lupus. So she's had a lot of steroid over the years, and she's had hydroxychloroquine at a high dose. And her usual ophthalmologist is quite concerned about macular toxicity with her high cumulative dose. He did her first eye cataract surgery, and this lady is a little bit tricky also because she's a little bit of a low myope. So she told me that she wore glasses for distance, just a small prescription, and when she got into her 40s, she wore some reading glasses. And when cataract surgery was discussed for her first eye, her dominant eye, she was offered, look, distance or near, and was told anything else, the technology is just not there. So they went for distance, and on paper she's had a good result. She's 6'6", right? She's plano. She's had a ZC Boo lens and everything looks perfect, but actually she's unhappy with her near vision, and she's also got dysphotopsias in this dominant eye. So she's seeing halos at night and halos when she's driving. She's also got a clinically significant cataract in the other eye, so she's only refracting up to 618, struggling there. So we talked about options here. She was keen to have a little bit of extra range. The range is the word I like to use with my patients, but I would really not be keen to put any more complex optic into an eye that has been identified at risk of macular toxicity. So macula is normal at this stage, her autofluorescence is normal. She's got a slightly longer axial length, but again, biometry is not too exciting. So we discussed options. I would not put a multifocal in her. I wasn't keen to use the same type of lens, of course, with dysphotopsia in the first eye. So I went with the hydrophilic product, and we went for a low myopic outcome. And the aim was predicted for -0.64, because that was closest to my -0.75, which I'm sort of finding is what I like here. And this went well. So she said her distance is okay. It's not as good as the other eye, which is fine, but the computer vision is great. So she's really comfortable on her computer, and for small print, she's putting on some glasses, and she has no dysphotopsia. So I've given her some range. The lens is doing what it says on the tin. You have to be really careful that you're not promising complete spectacle independence, but I was happy with that. I've got a third case, and so I'm going a little bit more off-piste now with my cases. So, one of my friends and colleagues in London, Alan Barsom, saying, look, I'm just kind of using this lens now as my kind of everyday lens. This patient is a VIP. So his niece is an optometrist who sends me lots of patients. So he gets the VIP treatment, and she wrote to me saying, please see Uncle, and maybe he could have an EDOF or a multifocal lens. He's got a lot of complex medical issues, including cystic fibrosis, had a lot of hospital stays over time, so not really keen to have too much intervention. And he's a fairly hypermetropic patient with garbage distance uncorrected vision, 675 and 660. But incidentally, I've noticed with him that he's got EBMD. And you do pick that up not infrequently, don't you? So that sort of, particularly those superior areas, you might not even notice them if you don't lift up the lid, but those areas of reverse staining, no erosions, and he's got cataract also. Normal macula, and his biometry, a low degree of SIL, but remember we put a toric lens in virtually everyone in Australia. And I'll show you here. So you can see actually on the central topography scan here, the cornea looks a little bit irregular. and things are a little bit elevated in the superior cornea on the topography there. So this is something that I talked about with Anchal. So, you know, someone who perhaps if they were keen to, you know, really pursue an extremely regular cornea, we could debride that epithelium, we could do a PTK, smooth things out. This guy doesn't want additional procedures, just wants cataracts done, and he'd like to have less reliance on glasses. So I was not keen on a multifocal or even something really like a Vivity. He's a VIP, remember? I want to give him good visual function, and I don't want him coming back unhappy with glare and halos. So we had a long chat about it. He wants a little bit more than just distance vision. So we went for the EMV with a mini monovision plan. And we did well here, I think. So he's certainly happy with distance vision, near vision improved for all but small print. So there's this kind of theme here, isn't there, where, you know, functional vision, most of the time you're all right, but you're not going to see the tiny print on your eye drop bottles. So with the distance eye, which was the right eye, 6/6 part, again with a little bit of a myopic refractive error, and with his near eye, so I aimed for -0.75. I have been trending to see my EMV patients coming out a little bit more myopic in the majority of cases. Are we not refracting them properly? Is it the A constant? Refractions are a little bit more challenging, and I'm not sure of the accuracy here. And we need to do a better job in our practice to push more plus to really, really find out how we're tracking there. So just a few of my cases, and I've had one patient who also has EBMD who's come out around +0.75 in either eye, and I've been back and I've checked her measurements, and she's actually nice and regular centrally, but my trend is either that we're getting good uncorrected vision or a little bit more myopic than expected. So it'll be interesting to see how A constant work evolves over time. So they're my cases, and I've just put in my slide a summary of my presentation from earlier today, which was just a brief look at their toric stability. And so really, it's good. So for a small group of patients that I looked at, this was 38 eyes, we had 3-week follow-up, and the mean absolute rotation, so we haven't taken into account direction, was 1.3 degrees, so they're staying put really well. And at 3 weeks, 100% of eyes had less than 5 degrees of rotation. The majority not moving with just a small degree of movement, anti-clockwise about 30%, clockwise 20%. So that's comparing the intended position with the post-op position at 3 weeks. So very small magnitude, not clinically significant, but you know, interesting to think about how the haptic design could have played a part there, or did I just put it in the wrong place in the first place? Anyway, that's it.
So my pleasure to introduce the next speaker. And Dean, I've known you since you were an earnest fellow from New Zealand / Melbourne, and I've seen you just grow into, you know, one of the elite. I mean, you did the extended depth of focus work with Symphony originally from New Zealand, so I was delighted to hear that you were involved in the Rayner lens, and looking forward to hearing your thoughts. And Dean will discuss EMV in practice, what Rayner say, and how that matches my experience and results.
Thank you, Graham. So we're still talking about which IOL, and I'm operating now in 2 sites, one in Auckland, which is a large multi-centre practice, and one in Queenstown, which is a lovely place to be. These are my financial disclosures, and these are some but not all of the intraocular lenses I've implanted over my career. What I've been asked to speak about is the EMV in my practice in a practical sense. So without wanting to bore you, this is an extended depth of focus lens based on spherical aberration, and we know that a neutral lens will give us a very fixed focus, and the cornea has some positive spherical aberration. If we add to that, we add to our depth of focus. So this is the principle of using either a monofocal lens to deliver what the range of focus is going to be, or using a lens with an extended depth of focus such as this for binocular emmetropia. It's going to give them better intermediate vision. And we've talked a lot about optics, and Damien and Graham are experts in this area, but my understanding of optics is you can't take something and deliver it without reducing some aspect of what's happening in the optical system. So not surprisingly, compared to a spherical lens, there is a reduced modulation transfer function of a lens that is increasing spherical aberration. The other concept that we've already touched on, and I don't want to labour the discussion because I think everyone here is very familiar with the concept of monovision. And if we use this extended depth of focus lens in a monovision setting, we can actually extend it to a much more functional range of vision. When we go to the operating theatre, and it's been an interesting exercise to move to a very new operating theatre in Queenstown where the nurses are not trained, having a product that I don't have to load and is an absolutely excellent product to use in my hands with this fully preloaded injector is an absolute bonus. And you know, this product's been really well designed. It's one of the best preloaded injectors I've ever used. It folds the lens beautifully, and the wound size is very attractive for us. It's a 2.2 millimeter wound size without any concerns whatsoever. And the lens product has been designed to centrate within the bag, and it is one of the most beautiful lenses. Rayner's been around for a long, long time, and their IOL design in terms of its ergonomics is absolutely fabulous. So we'll play the video. For those who haven't used the product, it really is an injection of viscoelastic into the cartridge, folding the cartridge closed, which folds the IOL, and then we introduce it into the eye. And in my experience, this is not one of my videos, but it really will go straight into the bag without any extra manipulation. It unfolds very smoothly and slowly, and I can generally get both haptics in the bag without a secondary manipulation as we see here. So moving on to my early outcomes, these are defocus curves from my practice, and here's our monofocal IOL. And in yellow, it might be a little bit difficult to see. The eye hunts, we've got a slightly extended depth of focus. We've already talked about how we center our refractive error, but we can see that there is an extension of depth of focus here with the eye hunts, but it's very modest. And here's the EMV. So if we look at the depth of focus from the eye hunts and the monofocal, we're looking at about 0.8 diopters. This is my personal outcomes. But if we look at the EMV in an early series of about 16 patients, it's 1.6 diopters, which is even better than might have been demonstrated in some of the other defocus curves. So it's definitely behaving very nicely from a functional point of view. So I'd just like to share a case presentation. A 65-year-old plus 3.5 diopter hyperope, great person to start with, and unremarkable examination, good corrected vision. The word cataract annoys me a bit. I think that everybody over the age of 50 has cataract. It's a cloudy lens, and cloudy lenses start at about the age of 30. If you look at a 20-year-old's lens and you look at a 40-year-old's lens, they don't look the same. So it's a kind of a silly word. I talk about cloudy lenses, and people kind of understand that, and I use the term lens replacement rather than cataract surgery, and that creates a lot of acknowledgement and understanding. I think it'd be useful for us to all move in the same direction. I really, if a patient has good corrected vision before I'm going to embark, I will almost always recommend a contact lens simulation, trying to confirm to them that this is not a slam dunk. You've got to have some skin in the game here, and committing them to a contact lens simulation helps me understand their visual system a lot better. So it's a little bit like going through the biometry, making sure the biometry is right. This is prepping the patient to understand whether they're going to be a suitable candidate to introduce the degree of splitting of perception between the two eyes. And he did well. He had astigmatism in his right eye, so I decided to use an eye enhance in the right eye and in the left eye an EMV, simultaneous same-day surgery, and he was delighted, unsurprisingly, with excellent function. And the refractive targets, you know, we can all decide what they are. So the conclusions I have is that the EMV lens is a terrific option with an emmetropic target to give patients intermediate vision. It's a great starting point for people who want to give patients more than what a monofocal will give. EMV with mini monovision is really going to potentially deliver terrific functional vision for people. Michael was talking about not using N as a measure of near vision. I kind of disagree with him. Everybody's got different length arms. It actually depends on where they want to hold something and where they functionally use it, as opposed to what is going to be a measure at a given distance. Everybody's got different distances and different roles that they want to achieve their visual outcomes from. We know that, we've talked about that, and again, it's a terrific product to use, and it's a proven platform from a great company that I think has shown us great persistence in the market and support of their products. Most importantly, there's no dysphotopsias. And as Graham has alluded to, I've been using Symphony for a lot of years. It's a diffractive IOL. It has rings. I've enjoyed the depth of focus that it's delivered for my patients. So I have a question. Is this intraocular lens a default monofocal IOL? On the flip side, is there any risk of using a conventional monofocal? And you may say, no. I guess it depends on how you define risk. So what's the risk of a standard monofocal? It happens to be these things. And Karl, it's amazing the synergy and similarity of our approaches that is really coming together in this day and age, I think, of what we're trying to deliver. You know, there's a lot of marketing around glasses. They're an appliance and they're a crutch, in my opinion. That they deliver poor peripheral vision. They're absolutely useless for our regular activities. And as Karl's already said, they cause accidents and people die from wearing glasses. Thank you.
We're going to have the next talk. So introduce Brian. Brian, you're always looking laterally and trying new things. And you're one of the first surgeons in Australia to use Rayner EMV. But today you're going to tell us about a case study and particular results.
Yeah.
Thank you, Brian.
So background, I've got 18 months experience with EMV, and that will be presented tomorrow. And 10 days ago, this lady presented for a 3-week post-op, and I decided, no, this is something we need to talk about. So it's a quick case study, and then we'll be eating. And I'll just put my EMV glasses on. It's bloody hopeless. Who invented this EMV?
What's Dean?
Don't fall over, Brian.
It doesn't work. Okay, yeah, I can read that one, yeah. Anyway, so this lady is, it's fairly unique case history. I've known her for 30 years. She's the executive to the surgical director of Prince Alfred Hospital, where I've been for 30 years. So when she was young, she had pigment dispersion syndrome with pressures that would fluctuate, and her past history is spherical equivalence around about -3 in the right arm, -275 on the left. She has had esotropia as a child and strabismus surgery and suspected right amblyopia but not confirmed. and occasionally she'd get intermittent diplopia. At a time, I said, oh, it looks like we need to control your pressure because the fluctuation. So we gave her some glaucoma drops, and she was completely non-compliant. She is light sensitive, she's drop sensitive, and prone to red eyes. She's got a Celtic pale skin, and she really didn't enjoy drops, and so she didn't use them. So my issue was I need to control pressure, so we introduced SLT, which worked well for several years. And probably 2 or 3 years she wouldn't come back for follow-up. So she was a problematic patient. And I knew that. So she says, can you do anything for my vision? I said, well, hang on. We need to do something for your pressure. Your pressures have gone into the 20s, and you're non-compliant, and we've used laser. We need to look at pressure management. And she says, well, can you do pressure and vision at the same time? And I thought, oh, well, why not? I'll just phone Dean Corbett, ask him what to do. Anyway, it's a difficult situation where she has a preference for reading. I know she's got iris transillumination. She's light sensitive. She's never going to handle a multifocal implant. So what do you do? Well, she enjoys her sewing, and she works on computers, avid reader, and she's prepared to accept distance glasses. So we had a chair time of 1 hour over several visits. I'll run through her examination: 67.566, vertometry -375 plus 125, 81, -375 plus 175 at 10. Pressures outside the range, and she has some disc cupping, but interestingly the disc morphology didn't change over 20 years. She had all the features of pigment dispersion syndrome, including a Krukenberg spindle. And as you can see, the disc morphology is not 100% normal. She may be losing some ganglion cells and some superior retinal nerve fiber layer, but that was a priority. We have to get her pressure down and reliably keep it down. And if you remove her lens, you're going to remove the stimulus for pigment dispersion, and we also get a pressure reduction standard with lens removal. And so I decided we should do lens-based surgery with eye stents. Now to choose the lens. So I chose a RayOne EMV toric. Now I'm not a monovision advocate. I'm more multifocal mini monovision. So the aim was -129 right eye, -118 left eye. So there's a good chance I'm going to get -1.5, -1.6, but so what? She'll wear glasses. So day 3 post-op, she's 6:15, she's 6:12, reading N5, very happy. She's got a near vision, and she's quite impressed with the distance vision. She's the type of lady who'd walk around the house without glasses, so she accepted distance blur, and 6:12 is outperforming her spherical equivalent -3. At 6:12, she said, oh yeah, my distance vision. And then at 3 weeks, she shows up, 6.6, 6.7.5, N5, N5, intermediate and near. So we've hit the jackpot, but you can still refract her. And this is where Warren Hill would say, yeah, refraction. But the bottom line is if you add minus, she sees even better. We didn't push her to 4.5 or anything like that. But we got a pressure reduction, and we've outperformed. If we look at her defocus curve, if we look at the green line and the red line, we were targeting maybe 6.9, 6.12. We weren't really expecting 6.6. So there's something in her eye that's allowing us a surprise factor, and it's not something we can complain about. It's possible you will need night driving glasses, which is not the end of the world. Mm-hmm. And if we made you some sunglasses, we might put some minus correction in that so it's even sharper in your sunglasses, but it's not necessary.
Previously, I was never ever able to drive in daytime without glasses. Now I can.
That's wonderful. Would you recommend this lens again to anyone else?
100%.
Fantastic.
100%. Thank you very much.
Pleasure. What do we want to do? We wanted to, in this case, we wanted to maintain near vision, but obviously move it away from -3. So we're going to make it more practical. She's fully aware she will not be able to achieve driving vision unaided. We needed lower IOP. And what has happened, she's outperforming in the distance. She's independent of glasses for near tasks and most distant tasks. I suspect she will need photochromatic distance correcting glasses and possible night driving glasses. Thank you very much.